Good evening. Welcome to all participants of today's webinar organized by the HyperChildNET COST Action Network and European Academy of Paediatrics. My name is Artur Mazur. I'm from Poland. I'm a HyperChildNET COST Action Network member and also head of the Adolescent and Medicine Health Working Group, European Academy of Paediatrics. It's a great honor for me welcome the President of the European Academy of Paediatrics, Professor Berthold Koletzko, who will chair today's webinar. Professor Koletzko, welcome to our webinar. Ladies and gentlemen, the COST Action HyperChildNet is aimed at the establishing European sustainable and multidisciplinary network of the international renowned researchers, clinicians, health economists, decision makers, patients, and medical devices manufacturers, focusing on acquiring a holistic understanding of the factors affecting high blood pressure in children in order to propose and implement a corrective and preventive action both globally and locally. Please next slide. From the 3 last years, HyperChildNET COST and European Academy of Paediatrics working together. Please next slide. One of the main results of this cooperation were statements. Please next slides. There were joint statements about the assessing and managing high blood pressure in children and adolescents, and also a statement about how to manage high blood pressure in children and adolescents, and how to correctly measure blood pressure in children and adolescents. This next slide. During next webinar, today and next week, you will have to opportunity to listen lectures by authors of those both publications. Today, our speakers will be Professor Peter Hoyer, Professor Empar Lurbe, Professor Stella Stabouli, Professor Dorota Drożdż, and Professor Olena Nyankovska. This next slide. Next week, our lecturer will be Professor Sarah Erdin, Professor Giuseppe Mazzia, Professor Augustina Januskiene, Professor Mieczysław Litwin, Professor Małgorzata Wójcik, Professor Elke Wöhl, Professor Thomas Siemen, and Manish Sinha. So, world famous speakers and researchers on the field of hypertension in children. This next slide. Together with European Academy of Paediatrics, HyperChildNET COST will disseminate information about the current decision, current diagnostic and management information, and next information about the European Academy of Paediatrics. I would like to introduce Professor Koletzko, and Professor Koletzko, please say us about the EAP and EAP aims and activities.
Thank you very much indeed, Artur. It's a huge pleasure and a privilege to participate in this exciting event. The program looks amazing. Obviously, hypertension in children is a very important problem. It occurs very frequently, and we all know it has severe long-term adverse consequences, but is often overlooked. So I'm really glad that attention is put to this problem. And for the European Academy of Paediatrics, it's a real joy to join this effort. The European Academy of Paediatrics is the united and strong voice of pediatrics and child health in Europe. We are the umbrella of as many as 52 national pediatric societies and 14 pediatric subspecialty societies. and affiliated with a number of further societies that are dedicated to pediatrics and child health. Our mission is to protect the health of children, as well as to support pediatrics and pediatricians in Europe and beyond. And we do this with a number of activities. Some of our core activities, but also Professor Hoyer, who speaks in this seminar a bit later, is very actively involved, is to promote training and certification in pediatrics and the pediatric subspecialties. We are incorporating the European Board of Pediatrics that defines the training standards in the European Union. And we also do a lot of advocacy and policy activities. I just want to highlight some of our opportunities, our upcoming events. Next month, in April 12 to 14th, we have an exciting master course on infectious disease and vaccination in the beautiful city of Porto in Portugal. In October, together with the European Society of Pediatric Research, we are having the European Pediatric Academic Societies Congress that provides an update on developments in all of pediatrics. On November 19, we offer the online examination in core pediatrics, which is a wonderful opportunity for our younger colleagues to test where they are in their training and where they may have gaps that need to be filled. And 1 month before, at the end of October, there will be also a course to prepare for this, the core pediatrics course, also online. So look at the EAP website and you'll find more information. This, as you see now, is the EAP master course in April on infectious disease. You see the website eap-congress.org if you want to find more information. And the next slide, Artur, if you can kindly move it forward, is already thanking you for your kind attention. I hope you will look at the EAP website. I just want to mention every pediatrician who is a member of his national society is also a fellow of the European Academy of Paediatrics. So you're invited to participate actively in our activities. Now, without further ado, I just want to invite our first speaker. She is really an amazing colleague. Dorota Drożdż is a specialist in pediatric nephrology and hypertension. She heads the Department of Pediatrics, Nephrology and Hypertension at the Institute of the Jagiellonian University Medical College in Krakow, Poland. She has long-term experience in treating children with renal disease and hypertension. And she talks today about the important topic, when to send the patient to the specialist. Dorota, the floor is yours.
Good afternoon to everybody. I would like to thank the organizers for organizing such important webinar and also for inviting me to this interesting topic. As already mentioned, last year, there were published 2 very important manuscripts where you can find the answer to this question, and also many other practical advices. So when to send to specialists, it is clearly shown in this statement. Then when we measure the blood pressure in a child at the age of 3 years or more, and evaluate that the child has a higher blood pressure, elevated blood pressure value, we should invite the child and the parents for the next visit during 1 or 2 weeks and measure again. And if the high blood pressure persists in 2 or more occasions, we should refer to specialists. Of course, we also recommend to perform home blood pressure. And in the other situation, when we measure very high blood pressure, stage 2 hypertension, and our patient has symptoms like headache, vomiting, we should send this patient immediately to specialist. And if the patient has no symptoms, it would also be because of stress for example, such high blood pressure, then we should see this patient for the next time and check again the blood pressure. Next slide, please. What about younger children? In younger children, we measure the blood pressure in children from the risk groups with diseases like chronic kidney disease, solid organ transplantation, history of neonatal intensive care unit hospitalization, or with other systemic diseases with high blood pressure. These patients should measure the blood pressure at each medical visit, independent of blood pressure levels. And there are also situations when the children should be sent to the specialist. Next, please. Why should we really at the early stage of checking the blood pressure or diagnosing the hypertension sent to the specialist? Because at this first step, when we measure the office blood pressure, we should perform an ambulatory blood pressure measurement to confirm the hypertension is necessary before starting the treatment with antihypertensive drugs. And as you see on this schedule, simultaneously, we should check if our patient has already target organ damage, so we should have access to cardiologists, which will perform echocardiography. And we also have to check kidney function parameters like GFR or albuminuria. Next, please. And let's start with the ABPM, ambulatory blood pressure measurements. Especially in children, this method is recommended before starting antihypertensive treatment to avoid pharmacotherapy in children with white coat hypertension. This method of measurements is very useful and provide us with many information. For example, if our child has a decrease in blood pressure during night, so-called dipping. If we see non-dipping status, it could be the secondary form of hypertension in our patients. As we can see on this slide, different diseases and different situations cause the non-dipping status, like obstructive sleep apnea, chronic kidney disease, or children with diabetes have often this non-dipping status. Next slide, please. Is it really so important? Yes, as it was shown in adult population, even a normotensive person, if this normotensive person has non-dipping status, the mortality risk is increased. Next, please. And from different points, we really see that the indication for a BPM are increasing. As I already mentioned, we should confirm hypertension before starting antihypertensive therapy in children with white coat hypertension, but we also have another situation when we diagnose left ventricular hypertrophy in a child with normal office blood pressure. We should also perform a BPM to exclude masked hypertension. As you can see, different risk groups like children with chronic kidney disease, with heart transplant or aortic coarctation need also a BPM on a regular basis. But as practitioner, I would like to point out on another indication, substantial discrepancy between office and home blood pressure. We see this really often in our outpatient clinic. Next, please. Not only at the beginning at diagnosing of hypertension, we should perform a BPM, but as you see, our patients with chronic kidney disease, coarctation of aorta, they should have the ABPM performed annually. And next, please. That's why I think we are all sure that children with secondary hypertension really need to be diagnosed and treated by specialists, as they need specific diagnostic tools, specific treatment of underlying disease, for example, cardiosurgery for recoarctation of aorta, or the care of nephrologist in case of chronic kidney disease. And they really need specific hypotensive treatment depending of pathomechanisms of their hypertension. Next, please. When we check if the children with secondary or primary hypertension are treated by specific departments, we can see that in nephrology or neurology department, almost more than 90% are treated because of secondary forms. And why is different situation at endocrinology department? Because many children are sent with obesity and overweight, and there are still children which we include to the primary hypertension. Next, please. In specialized pediatric hypertension clinic, they check the causes of secondary hypertension. As we can see, most children had renal problems, but also neurological, respiratory, and really big amount of children had high blood pressure because of medications used. And next, please. And once again, the kidney diseases, the renal artery stenosis, aortic coarctation, or pheochromocytoma, there are diseases, there are causes of secondary hypertension, but also the most common causes of severe hypertension in children. Next, please. That's why really, if we suspect or diagnose any kind of kidney disease, we should immediately send such a patient to the specialist. And as example, I would like to show you how complicated the treatment of patients with chronic kidney disease is. As we can see, these children have so many biochemical disturbances. They have so many traditional and non-traditional cardiovascular risk factors. They have already vascular and heart target organ damage, and they really need a specialized care. Next, please. And chronic kidney disease is on one hand the reason for hypertension, but also hypertension increases the progression of chronic kidney disease, and it is a very important study, ESCAPE trial. It was clearly shown that these children need intensified hypotensive treatment, and children with intensified treatment had slower disease progression. Next slide, please. I would like to show also how are the symptoms of renovascular hypertension in children, because this is often the cause of severe hypertension with headache, blurred vision, or heart failure. But as we can see, every fourth child has no symptoms, is asymptomatic. So that's why in children, we should have this specific diagnostic for all children because some of them could be asymptomatic and have really a secondary form of hypertension. Next slide, please. And if they have this severe hypertension, they really need very qualified and experienced staff to treat these patients, because we should lower the blood pressure, not too slowly and not too quickly, to avoid further complication in these children. So the children with severe hypertension and symptomatic, they should be treated at intensive care unit with intravenous drugs. And next slide, please. Our children diagnosed with hypertension, primary or secondary hypertension, they all need the assessment of target organ damage, and all children should have performed echocardiography to diagnose or exclude left ventricular hypertrophy, and also the glomerular filtration rate and albumin-creatinine ratio in the urine as the sign of kidney damage. Ophthalmoscopy is not obligatory at first diagnostic step. However, in case of severe hypertension, the patient should have also this examination. Next slide, please. So, a summary, we can find also the statement that screening for high blood pressure, baseline investigation should be done by pediatrician and family doctor, but we should early send the patients to the specialist to perform ABPM, to evaluate the etiology of hypertension, to evaluate the hypertension organ damage, and to start the treatment, the pharmacological treatment if it's needed, and to decide the drug classes. Next slide, please. So early referral to a pediatric hypertension center is recommended to facilitate timely interdisciplinary care, including cardiological and nephrological assessment. And next, as already mentioned, because you have to evaluate the blood pressure, as I would like to refer to the HyperChildNET website, where you can find the calculators. And thank you very much for your attention.
Thank you very much for this very insightful and clear presentation. I think this is great. I would like to share with everybody what is already in the chat, that you can write your questions in the chat. We will have a discussion period at the end of this webinar and come back to all the presentations and have an opportunity to raise questions and comments. You can already start to write them in the chat. And I also want to mention that this webinar is being recorded, so just to make you aware that we are doing a recording. Professor Artur Mazur is now going to introduce the next speaker.
It's a great honor for me to introduce Professor Empar Lurbe from Spain. Professor Lurbe is the chair of the HyperChildNET COST Action, emeritus full professor of pediatrics, University of Valencia, emeritus head of research unit at the Hospital General Universitario Valencia, group leader Cyberborn on the Instituto de Salud Carlos III. And I would like to ask Professor Empar Lurbe for the liberal lecture about the essential of blood pressure management and tools to reach target. Professor Lurbe, the floor is yours.
Thank you, Professor Mazur. Good afternoon to all. First of all, on behalf of all members of HyperChildNET, I would like to express our gratitude to the European Academy of Paediatrics for giving us the opportunity to work together in these webinars focused on hypertension in children and adolescents. Until early 1980s, little was known about childhood hypertension. Publication of early guidelines, despite limited available evidence, provide a framework to measure blood pressure for health assessment. Afterwards, a large amount of research has contributed to progress of knowledge. In fact, between 2016 and 2020, 3 guidelines have been published, largely based on evidence, with screening beginning at 3 years, and in which the thresholds to define hypertension were revised and future research established. Among these, life course blood pressure risk, the impact of early life on the development of hypertension and other cardiovascular risk factors, vascular phenotype focus on central BP and pulse wave velocity, and the impact of BP values on the development of hypertension-mediated organ damage in the heart, kidney, vessels, and central nervous systems are hot topics of research together with out-of-office BP, in other words, 24 hours ABPM and home BP. Even when important progress of knowledge has been achieved, next please, many gaps are still open. Among the most mentioned in the literature are the prevalence of childhood hypertension has been difficult to state. There are limited data on the accuracy and reliability of automatic devices. The need for a practical and sustainable approach is absolute. There is a lack of reliable goals to achieve for control. Deficiency of information based on clinical trials on lifestyle changes, and limited information in labeling drugs for long-term antihypertensive treatment. Considering these gaps, one more step to move forward would be to better understand the main factors underlying the gaps. Next, please. During the next few minutes, I'm going to review with you the difficulties to define normal values, which factors contribute to BP elevation, the cluster of cardiovascular risk factors, and to finish off with expected impact in future cardiovascular events. Next, please. What are the difficulties to define normal values? In children and adolescents, blood pressure increases during growth and maturation. Then it is difficult to establish a fixed cut point. High blood pressure variability, consequently, to define hypertension needs to be persistent on 3 separate occasions. And from a methodological point of view, oscillometric versus auscultatory. Next, please. In 2016, the European Society of Hypertension guidelines in children and adolescents were published. In this case, the diagnosis of hypertension was based on a specific 95th percentile for age, sex, and height up to 16 years of age. 16 years and older, fixed cut points, 140/90, the same cut points that for adults according to the ESH guidelines. 1 year after were published the American Academy of Paediatrics guidelines. Please, can you back to the previous one? And in this case, the American Academy of Paediatrics established the diagnosis of hypertension based on the 95th percentile specific for age, sex, and height up to 13 years old. 13 years and older fixed cut points. And in 2020 were published the Canadian guidelines. In this case, the 95th percentile specific for age, sex, and height was applicable until 6 years of age. Then, overall, the guidelines differ at the age in which the fixed cut points were established, as well as in the fixed cut points. Next, please. On the other side of the coin, the 3 guidelines are in agreement that to define hypertension needs to be persistent on 3 separate occasions. This is a meta-analysis in which a large number of subjects were included with age range from 3 to 20 years. During the first exam, the prevalence of hypertension was 12.1%, decreasing progressively up to the third exam in which it was 2.7%. Interestingly, these differences were independent of age, sex, ethnicity, and the definition of hypertension. Next, please. What is the prevalence of hypertension in children and adolescents? This is a meta-analysis in which 47 studies were included. Was performed in a general population, and childhood hypertension was based on blood pressure measured by mercury sphygmomanometer and persistent during 3 separate occasions. The prevalence of hypertension was increasing progressively from the year 2000, 2010, and 2015, with a peak between 14 and 15 years old, and afterwards decreasing progressively up to 19 years old. Overall, the prevalence of hypertension was 4%. However, there are differences according to body weight. In normal weight, the prevalence of hypertension was less than 2%, 1.9, achieving 5% in the presence of overweight, and increasing to 15.3% in the presence of obesity. Next, please. Together with the most mentioned gaps in the literature, it is important to know which factors contribute to high blood pressure. Sodium and potassium intake, as well as sugar-sweetened beverages, have high impact on diet. On the other side, screen time, sedentary life, and sleep disorder while interacting negatively influence physical activity. In addition, fetal factors and maternal conditions need to be considered. Next, please. Among those factors that contribute to BP elevation, the main attributable risk factor is BMI, but also waist circumference and sodium intake. Next, please. But not only sodium intake, but also potassium intake needs to be considered. This study was performed in states in adolescents 12 to 14 years old coming from the enhanced cohort. In those participants in which the sodium intake was higher than 7,500 milligrams per day, potassium intake lower than 700 milligrams per day, or sodium-potassium ratio higher than or equal to 2.5, are more prone to develop systolic hypertension. Next, please. Moving on to the cluster of hypertension with other cardiovascular risk factors, this study was performed in our department, including moderate obese children and adolescents. 1 out of 3 had high insulin, 10% high BP, and 12% low HDL. High blood pressure was associated with high insulin in 10.6%, and in 8% was present high blood pressure and low HDL. Next, please. Uric acid has received more attention recently. As we can observe, as uric acid increases office systolic BP, increases triglycerides and HOMA index. In contrast, decreases HDL cholesterol. Next, please. Today, it is very well recognized that the life course perspective may be the optimal way to understand adult health and disease. In childhood, it is extremely rare to suffer the adverse cardiovascular events experienced by adults. However, cardiovascular and metabolic disease risk factors may already be present and related to the development of future adult cardiovascular disease. What is the challenge? The challenge is to elucidate the main risk factors, know when and how to assess these factors, and discern how to manage them in children and adolescents. Next, please. A seminal study was published in the New England Journal of Medicine in May 2022, assessing the impact in future cardiovascular events. The study was based on the International Childhood Cardiovascular Cohort Consortium. This is a prospective study starting during early childhood, throughout adolescence, and subsequently during adulthood. With a large number of participants and with a mean follow-up of 35 years. A set score for the risk to suffer cardiovascular event was calculated taking into account 5 cardiometabolic risk factors: BMI, systolic blood pressure, total cholesterol, total triglycerides, and smoking during adolescence or during adults. The set score was ranging from -0.5 to higher than or equal to 1.5. As can be observed, as set score increases the risk for cardiovascular event. And even more. Next, please. The impact of Z score was observed even in adults younger than 47.7 years of age. With all of this in mind, next please. What does it mean for practice? If cardiovascular risk factors are identified early in life, we might address health issues early to uncouple risk, and even more, don't lose the opportunity for primordial prevention. This brings to mind a Chinese proverb: when the winds of change blow, some people build walls and others build windmills. In this way, the task force of the European Society of Hypertension Guidelines in Children and Adolescents was aware of the problem and the need to move forward in the field. The question was, how did we choose the best instrument for improving knowledge working together? And we look at the European Commission. There was the Cost Action Program. A proposal was submitted, approved, and funded for 4 years. The key elements of the Cost Action HyperChildNET were published in Hypertension, please, the previous one, in April 2023. HyperChildNET is an interdisciplinary network in which are participating members of 26 European countries. The key activities of HyperChildNET are based on the core action, research, dissemination, and training, carrying out successful virtual mobilities and short-term scientific missions, in this case with a special focus on young researchers and inclusive target countries. In HyperChildNET, there is an active involvement of stakeholders. To go ahead with the work plan, 5 working groups were created. Next, please. The working group 1 is focused on devices, working group 2 on reference values for office BP in Europe, working group 3 to know the impact of BP values on the development of hypertension-mediated organ damage. On prevention is focused working group 4, and on dissemination, working group 5. Next, please. Concerning the cooperation with societies, next, please. A synergistic action between HyperChildNET and European Academy of Paediatrics was a joint statement published in Frontiers of Pediatrics, the official journal of the European Academy of Paediatrics. Next, please. The joint statement has 2 chapters that were prepared in a very practical way, with schemes, tables, and with a link to 3 free online calculators. Next, please. These are the QR codes for the calculator for office BP, for 24 hours ABPM, and for home BP. Next, please. So far, the blood pressure calculators have received a large number of visits, almost 28,000 visits, with an average of visits per month of 3,000. The highest number of visits were for office blood pressure calculator, the lowest one for home BP, in the middle 24 hours ABPM. Next, please. In the field of pediatric hypertension, there is a long way to go. In the middle of the road is HyperChildNET. HyperChildNET offers a European perspective on hypertension issues. Next, please. Joining forces between the European Academy of Paediatrics and HyperChildNET will help to move forward in the field. Thank you for your attention. Next and last.
Thank you very much for your wonderful presentation and the outlook into the future. I'm sure we'll have comments and questions at the end. Again, dear colleagues, if you have questions, don't forget them. You can already write them down in the chat right now, and we'll come back to that at the end of the question. It's now my pleasure to introduce as the next speaker a truly outstanding colleague and a very good friend. Professor Peter Heuer is Professor of Pediatrics at the University of Essen in Germany, where he also served as Department Chair of Pediatrics. He's an international renowned specialist in pediatric nephrology and kidney transplantation. He has also served as the past president of the European Academy of Paediatrics. For many years, Peter has been very actively engaged in promoting standards of pediatric training, and currently he's also the director of the European Academy of Paediatrics and European Board of Pediatrics examination, which, as I said before, you really want to recommend to your trainees to participate in. And as I mentioned, the next exam will be held on November 19 this year. Peter's topic today probably relates to something that is not only relevant to hypertension, but also several other areas of clinical medicine, gaps in adherence to clinical guidelines, how to overcome them. Thank you, Peter, for participating.
Yeah, thank you very much, Bert, for your kind introduction. And indeed, the title you gave me is a challenge for me after these excellent presentations I heard already, and the great vision and the great work Empar Lurbe has presented. I have to go back to the roots and discuss with you the problems we have. First of all, I have to mention that I have nothing to disclose, and I here mentioned the most important literature I use for my presentation. Next slide, please. So during the last 20 years, did we improve? And I just want to emphasize what Empar Lurbe was saying, and it's important up to date. There's a lack of awareness of importance of high blood pressure in children. Indeed, there's growing evidence that children and adolescents with mild blood pressure elevations are much more common than it was thought in the past. Despite all the detailed information we heard already and the pathophysiology, I think this sentence still is true. Next, please. So there are, of course, historical reasons justifying omissions of children's hypertension and previous guidelines. As you know, clinical care of children and adolescents on one side and of adults on the other side are entrusted to different sets of physicians, and it means that the understanding of hypertension is a different one. The data and arguments on which recommendations for high blood pressure in adults and respectively in children are based on different concepts. So diagnostic criteria for elevated blood pressure in children are based on the concept that blood pressure in children increases with age. I think this is very simple, and with body size. And the disadvantage, make it an impossibility to utilize a single blood pressure level to define hypertension as done in adults. And I think we should be aware that many adults also care for children. And there are no prospective studies which sufficiently long-term follow-up directly linked to childhood blood pressure to the occurrence of cardiovascular disease mortality. So one important, I think, paper was published by Diego van Esso almost 10 years ago. And he showed the pediatric and the GP care for children throughout Europe. And as you can see, we have three systems. We have the pediatric-based systems. We have a system based on GPs and family doctors, and we have a combined systems. So there is a huge difference among European countries. And please, next slide. As you can see here, Manuel Katz reported data about 2000, and you can see the pediatric system was, important or providing care for children in about 35%. 10 years later, it decreased to only 24%, while the GP system increases from 18% caring for children to 41% of children. So why I'm going, next slide please, to mention this, it is that the spectrum of care is so different, and if we address, the specialized knowledge we have as pediatricians, not to adults and GPs, I think we really will have problems to transport the knowledge. There's a huge knowledge about hypertension, which you can see in the literature. In about 10 years, the number of papers, if you go to PubMed, under the search high blood pressure in children and adolescents, you see we have in the first 10 years during this period, 20,000 papers per year, and now we have more than 4,000. 2,000 papers per year, now more than 4,000 papers per year. So I think it will be very difficult to get an overview and really to catch the newest and important information which we need to care for children with high blood pressure. Next slide, please. So what are the problems? Going back really to the basis, also we know all the scientific data. In the hectic daily routine of a doctor's office, measuring blood pressure in preschoolers and anxious children can be difficult, this we know. And we know that single measurements are often very erratic. But to organize repeat measurements is always very important. If you have a child coming to an office, which may be an infectious disease, then you might have another focus. And then if you measure the blood pressure and you are organizing that the child comes back for a repeated measurement, then it will be difficult to organize, especially if the children live in remote areas. So it's clear that the main reason for consultations in the office are acute or have a clear other focus than blood pressure. This we should not forget. Therefore, I think blood pressure is quite often not considered to measure. But I think at this point we have to mention and to educate people that, however, in certain risk patient groups, it is essential to ensure that blood pressure is measured and not missed. That is, I think, the main message. Please, the next one. So possible surrogate and most valuable biomarkers. We all know of hypertension and end organ damage. Are they really used in reality? I think, as is mentioned, left ventricular hypertrophy needs a cardiologist. And I can assure you, I know many cardiologists you ask to do that, and they measure just, the thickness of the myocard and not calculating the myocardial mass to define left ventricular hypertrophy. Blood vessel thickening and stiffening of large arteries are well known, but this is available even in Germany only in very few specialized centers, so we are far from using this. And kidney parameters like urine albumin excretion, also I'm a nephrologist, I must say in the general population, it's a late biomarker and rarely seen in children. If you have already the diagnosis of renal disease, of course, then it's not a problem. Next slide, please. So we have many recommendations to measure blood pressure, office blood pressure, as already mentioned, and they are all correct, and I would underline this. But if you talk to physicians working in the practice, it starts with the problem to have the right cuff size for children. Many offices have maybe one for children and one for adults, but this is, as we know, not enough. And then you see also the different measures, 4 times 8 or 6 times 12, 9 times 18, and 10 times 24. This is all correct, but is it really used in the daily practice? And I doubt that this is really, really used. So I think we should go to the next slide. So, okay, I have some disturbance of my screen. So I think this picture is nice and I like it. It's from the American Academy of Paediatrics. But I would really ask you, how many doctors working in the ambulance are really measuring this? For scientific purposes, I think you have to do it. But I think it's more or less that people get an impression and then they use the right cuff, which usually should be there, but many of them don't have them. Next slide, please. And there are many, I would say, devices to measure the blood pressure also at home. But if you see all these devices, the question is, are they really, I would say, calibrated for the children? Are they reliable or not? There's a lot of literature. And I think it's not really, accepted that all of them are quite useful in children. Next, please. And something which has not been mentioned so far is if we talk about high blood pressure, we have to consider that there are different, I think, problems with high blood pressure. You have blood pressure varying within beat to beat. You have variation in blood pressure. We call it very short-term blood pressure variations. So that means variation between every 100 of beats. Then you have short-term blood pressure variation day and night. I think this is used in 24-hour blood pressure measurements, but it depends on, as you can see here, when you measure the blood pressure. And then you have midterm blood pressure variation, as you can see here, the calendar. So you might have different blood pressures Monday, Tuesday, Wednesday, Thursday, and so on. And then you have long-term blood pressure variation. This, as you can see here on this cartoon, variation between summer and winter. I don't know what is the reason for that. Maybe more activity and more sitting activities, and so in cold areas, I think it may be the reason. Next slide, please. So there are many tables you can use to look what is the right blood pressure and what is hypertension stage 1 or 2. But in the daily practice, and if I talk to colleagues, nobody has these tables in his pocket. And they know that there are tables, but they are not really using them. And I think Malcolm Coulthard published, because he knows this dilemma, this, I think, very useful diagram in colors where you can have a rapid look and see if the blood pressure is normal or elevated or stage 1 or stage 2 hypertension. The limitation of most of the studies is that they have diagrams for normal values and for hypertension in children aged 1 to 13 years of age. And then there is a problem that there are not enough data for older children. But there is one paper, or other papers as well, but I think this is one of the most important papers published by the American Academy of Paediatrics, where you can see the blood pressure development in children older than 30 years of age. And here you can see the 50s, 90s, and 95 percentile for boys and girls. And you can see also the different, depending on gender here. I think this is something very important and a very simplified chart which can be used. Next slide, please. So this joint statement is already mentioned, and I just can skip it. Next slide, please. I think the value of this table is very easy, but on the other hand, it's also a little bit confusing for people to really to keep it in mind. You have here also a different age category, patients less or children less than 16 years of age and children older than 16 years. And you have the categories normal blood pressure, high, stage 1 and stage 2 hypertension. And you can see in the younger one, it's classified by percentiles, but in the older one, it depends on the measured blood pressure. And I think also this might be something which leads to confusion and to keep in mind while you measure a blood pressure as a single blood measurement in the office. Next slide, please. So if we want to focus on the problem and we want it more easy and more acceptable, then we have the question, which target groups are particularly at risk? So next slide, please. I think there are in practice many red flags which can help you. First of all, the family history. If there are parents or grandparents with hypertension, cardiovascular disease, or cerebrovascular diseases, diabetes mellitus, lipid disorders, or hereditary renal disease, of course, these are red flags. The other one here I have mentioned are also rare diseases, and usually people don't know this. And of course, in specialized centers, you should know that. Next slide, please. The another red flags are the perinatal history, birth weight, gestational age, oligohydramnion, hypoxia, and of course, very important, umbilical artery catheterization, and the previous history, arterial hypertension, UTI, renal or urology diseases, diabetes mellitus, and so on. So these are simple red flags. I think everybody, even GPs, should know. Next, please, and should ask for this. So for me, to bring it all together, I think we have to focus on what we know, the common and the less common causes of hypertension. And the most important one here on the top is obesity, followed then by chronic kidney disease, we heard in the first presentation. Then we have, of course, renal vascular disease, but I think this is really overestimated. If you look how many children with renal disease have renal vascular hypertension, it's less than 4%. Then you have a few other diseases, coarctation of the aorta, it's always not so often, and usually cardiologists take care. But if you go further down, don't forget drug-induced hypertension. Ecstasy, for example, was mentioned. And something which is, I think, overlooked in most cases are the use of contraceptives. And I think young girls who receive contraceptives should have measured the blood pressure. This is very simple. Next, please. So let's focus on obesity. Next, please. I think the reason for that is one slide back. The reason for that is very obvious, and we know that this is sedentary lifestyle, so junk food, then Coca-Cola or other soft drinks, and I think not much or not enough exercise. This is very simple. And what was already mentioned was the hip-waist circumference as a risk factor. I think this is a red flag also, and you should really focus on the diagnosis and on the treatment of hypertension. Next, please. So I think we have to focus on the epidemiology of hypertension, and you can see very easily that in almost all countries there is an increase in the rate of obesity. The leading country might be the United States, followed by Mexico and UK, Canada. The Europeans are not so bad, but also there is a tremendous increase in obesity. And if we want to fight against hypertension, I think we should fight against obesity. Next, please. So the obesity epidemic in children and adolescents make it plausible that the prevalence of hypertension are increasing over time. And I just would like to mention some numbers which Empar Lurbe has already shown. Hypertension was found in 1.4% in children with normal weight. It increases to 7.1% in overweight children, and in obese children, it's already 25%. This underlines really the importance of this morbidity factor. Next, please. So the goals for the therapy and practice are, well known, and they are cited very often. It consisted of lifestyle recommendations to reduce high blood pressure values. I put a question mark on this. And as you can see, BMI less than 85th percentile, maintain BMI to prevent overweight when they are more obese, weight maintenance or gradual weight loss in adolescents to reduce. And then you can also read if children are very much obese, then the recommendation is gradual weight loss 1 to 2 kilograms per month to achieve. This might be all true, but does it really meet the reality? Next slide, please. So if you look to the literature and what is really the evidence of the recommendation of lifestyle intervention, and if you just look to the right of this table, then you see very low evidence, C, D, C, D, D, D. So we all feel and we know that it might help, but in real life, the evidence is not that robust. So next, please. So what should be realistically achievable by general pediatricians? I think this and the GPs are maybe the group which needs more education about. First of all, know the family history, the family setting, identify patients as risk. So the red flag, early referral to pediatric specialists. But what we can do also be advocates for healthy food and sport activities already in the kindergarten or later. Always focus on obesity, and also there should be more awareness of chronotypes and social jet lag. Next slide, please. What we have not discussed so far, and I just want to mention it, are the importance of racial disparities, Black, white, and Asian. I think this is something we have to focus more in the future. And a very important factor, and I can say also from my practical experience, are socio-economic factors like income, poverty, and education. Next, please. So my take-home message is cardiovascular disease are the most common causes for death. Focus on blood pressure is important. Prevention is the best, but hard to achieve. Next. The goal is early childhood intervention. That is the only one which might help. And here you can see the prediction for the United States. And we must ask ourselves, and in Europe, maybe you should follow the trends in the United States. So really, I think look for healthy food, early education might be a goal to improve the situation. Thank you very much. That's it.
Thank you so much, Peter. Artur, are you taking over? Artur, I think you're muted. Artur, I think you still need to unmute your microphone.
Stella?
Oh, yes. Thank you very much. Do you hear me?
Yes, we can.
Okay, thank you very much for amazing lecture, Professor Hoyer. And I would like to introduce our next speaker, Professor Stella Stabouli. Professor Stabouli is serving as Professor of Pediatrics, Pediatric Nephrology at Aristotle University of Thessaloniki, Greece. Professor Stabouli received medical and doctoral degree at the National and Capodistral University of Athens and continued training in hypertension and nephrology at the University of Mississippi Medical Center and the Nephrology Department of Boston Children's Hospital in the United States. Professor Stabouli is leading the group in the HyperChildNET COST Action on devices and chairing the European Society Hypertension Working Group on blood pressure in children and adolescents. Professor Stabouli, the floor is yours.
Thank you very much. And from my turn, I would like to thank the European Academy of Paediatrics and the organizers for the kind invitation and the opportunity to participate in today's webinar. So coming to more practical issues, I'm going to talk about how to measure blood pressure, starting with when, then discussing which blood pressure measurement it would be office or out of office and how to select, discussing the methodology of the different blood pressure measurements, and then discussing some challenges and limitations on the measurement methods. Next, please. Just briefly reminding what is already shown, that office blood pressure should be measured and blood pressure should be screened even at birth if there are high-risk conditionings, and this is maybe congenital heart disease, but also chronic kidney disease, which is the most common cause of secondary hypertension, especially in the younger children. And in these children, we should measure blood pressure at each medical visit, independent of the blood pressure elevation at first measurement. Next, please. But if we go in the older children, the general pediatric population, then we start measuring blood pressure at the age of 3, and then the frequency of repeating the blood pressure measurement at our offices, at the pediatrician office, depends on the blood pressure elevation. So if there is normal tension, then we may repeat our measurement in the next checkup. If it is high normal, then within the next 6 months. But if we have stage 1 hypertension, we should confirm this hypertension, the stage 1 hypertension, but this is not very important to do it on the next day, but do it in in a very short term, in 1 or 2 weeks, if the child is symptomatic. Otherwise, we can wait for more, but especially not very long. And if hypertension persists, then we have to refer to a specialist, as Professor Drożdż have already said. What is important is if we have stage 1, stage 2 hypertension, we have to evaluate the child immediately, even on the next day, and then refer to the patient to a specialist. Next, please. So going to which blood pressure measurement, office or out of office? And starting with office blood pressure measurement is the recommended method for screening, diagnosis, and management of high blood pressure in children and adolescents. This is common among all guidelines. But in the slide, we can see the table from the European Academy of Paediatrics common statements with the HyperChildNET, where we state that you can see there is, for the first 2 statements, there is a very good grade of evidence, grade B, that auscultatory or other validated oscillometric devices can be used for office blood pressure measurement starting from the age of 3. And what is important, although the evidence is less, is that we have to confirm this diagnosis on at least 3 separate visits. And why 3? Next, please. First, because blood pressure in children, but also in all humans, even in the adults, but it's more evident in children because in children blood pressure fluctuations, what we call blood pressure variability, is even higher because of their activity. And here you can see the output from ambulatory blood pressure monitoring. This is 3 different ambulatory blood pressure monitoring outcomes. The first is in a normotensive child, then into the 2 lower parts are in hypertensive children. You can see that there are a lot of fluctuations of blood pressure during the day. Actually, blood pressure changes from beat to beat. So 1 or 2 measurements in the office may not reflect what is the status of a child. So next, please. And already shown this meta-analysis that every time we measure blood pressure, we have a lower prevalence of blood pressure prevalence. And this is a meta-analysis of many studies around the world referring to screening studies at schools and about the prevalence of blood pressure. And you can see that studies that used only 1 measurement, they have reported the prevalence of about 13%. And this is coming lower, coming to less than 3% when we have 3 different blood pressure measurements. Next, please. Going to very practical recommendations, this is from the European Academy of Paediatrics and HyperCell statement, and reminding how to measure office blood pressure. It should be in neonates and infants. It should be performed in a quiet room with comfortable temperature. We should avoid feeding or sucking because this is exercise, and what we want to measure is resting blood pressure. And we, of course, should perform the office blood pressure measurement even if we are in a hurry, in a reasonable time after medical procedures. When it comes to older children, the patients should, especially the adolescents, should avoid smoking, caffeine, eating, or engagement in exercise 30 minutes before the measurement. The patient should remain seated and relaxed for 3 to 5 minutes before the measurement because, again, I repeat, what we want to evaluate in the office is resting blood pressure, and patients should not talk during or between the measurements. Next, please. Further practical recommendations include that the neonate and infants should be resting in prone or supine position, and when it comes to older children, the children should be seated but with back supported, legs uncrossed, flat feet on the floor. We may use auscultatory devices, as already said, or electronic or oscillometric devices. But in any case, if we use an auscultatory device, it should be calibrated. And if we use an electronic oscillometric upper arm device, it should be calibrated and validated for the age of the children. If we use auscultation, then we can use the Koletzko signs to evaluate, to define blood pressure. And if the first visit is high, then we should measure both arms and legs to detect pulse differences. And if hypertension is detected by the oscillometric methods, then because the blood pressure tables, reference tables are based on auscultation, we should repeat the measurement and confirm the diagnosis of hypertension with auscultation. Next, please. All these recommendations are shown in this figure, where most of what I already reported are shown, the temperature of and the setting of the room, the way that the child should be seated with the arm support, with the feet on the floor, the proper placement of the cuff, which should be around the arm circumference and be fitted 1 or 2 millimeters upper from the antecubital fossa. Again, the resting, you have to measure resting blood pressure, and this is very important because what we usually forget when we measure office blood pressure, especially in children, that is, we have to have the child seated for 2, 3, or 5 minutes. Next, please. So what I want to point out at this, and this is what we practically and very importantly, I think we refer in this European Academy of statement, is that there are very mistakes while we measure office blood pressure. Although office blood pressure is a very old methodology, and it is something that it is a common practice in our everyday practice. And the most common mistakes include methodology with a single measurement, with a noisy and cold room, talking or crying, no support on the back. Very, very frequently, we put the children in a very high chairs or high bed, and then the legs are hanging or crossing. Sometimes we are so in a hurry that we measure blood pressure over the clothes. And sometimes we also, because especially in the infants, because we cannot measure on the arm, we may measure blood pressure on a leg or calf. And of course, the issue of equipment, this is a huge issue, a big challenge for our society, is the small or large cars, the non-validated devices, non-calibrated devices, even using cuffs different from the device, that they not suit each other, so have an invalid measurements, and then the use of wrist or forearm devices, which is very frequently devices that are not recommended neither for adults. Next, please. So there is a lot of advantages of office blood pressure. The main advantage is that it's wide available. It has a low cost, it's easy to measure, and it has predictive value. It is very well shown by Professor Lurbe that cohort studies show the predictive value of office blood pressure, and this is an important evidence we have for children. But on the other side, it has a lot of limitations, the observer bias, especially the low number of measurements, the low reproducibility of measurements, the white coat effect, and the low availability of monitors. On the top of all this, I want to point out the lack of reference values for oscillometric devices, as normative values already existing for office blood pressure are currently based on auscultatory measurements. Then, next please. Focusing on devices, it's very important that this is one of the missing elements in our everyday practice. Devices has to be accurate to have an accurate blood pressure measurement and correct classify a child. Next, please. But when we made this systematic review search, this is one for the task of the HyperChildNET network with our cost action, were found that only 20 devices have passed the validation procedure for use in children. And this is very worrisome, because when we have to buy a blood pressure device for all blood pressure measurement, we have to know if it is validated. But actually, these very few devices are usually not commercially available, and sometimes our institution does not take care of whether it is validated, but it's only a matter of cost of which device has to buy. Thank you. Please, next. Moving to out-of-office blood pressure measurement, I would point out the advantages of ABPM, because ambulatory blood pressure monitoring can detect alterations in tachycardia and short-term blood pressure variations, identified specific phenotypes, and especially nocturnal blood pressure and mass hypertension. And also, what is unique in pediatric hypertension is that we have prospective pediatric studies on the predictive value of ambulatory blood pressure monitoring. Next, please. And going to this classic study by Professor Lurbe about the predictive value of ambulatory blood pressure and actually the nighttime systolic blood pressure and the nocturnal blood pressure pattern. This is predictive many months before an abnormal pattern, many months before the evolution in children with diabetes or the evolution of microalbuminuria. So in one of the high-risk population, ABPM has been proved to have a very important predictive value for target organ damage. Next, please. And of course, the randomized controlled trial, the ESCAPE trial, in another high-risk pediatric population, the children with chronic kidney disease, where here blood pressure targets based on ABPM show that if you use ABPM as a target for treatment, and especially low levels of ABPM, this is associated with better kidney survival in 5 or 6 years. So again, ABPM shows for target organ damage and for actually in this case for a hard outcome, which is kidney survival, an important predictive value. And this study is the study that for many years pediatric guidelines have been based and recommendations have been made. Next, please. If we want to discuss the advantages of out-of-office blood pressure measurements for ABPM, we can point out the large number of measurements, the better reproducibility of mean 24-hour day and nighttime mean values, the ability to assess blood pressure during daytime life, and of course the avoidance of white coat effect. Many of these advantages, especially the larger number of blood pressure measurements, could be attributed to home blood pressure, the better reproducibility compared to office, in addition to the availability and low cost of home blood pressure compared to ABPM, and also based on other studies, the ability to improve compliance. For ABPM, the main limitation is the low availability, the high cost, the importance of have trained staff, and also that is time consuming for both the patient and the doctor. While main limitations of home blood pressure is that it may cause anxiety to children and parents. It does not give information about daily life activities and also that we have few validated devices, and in addition that we have very few evidence on the diagnostic ability. So next, please. So ABPM, ambulatory blood pressure monitoring, is well accepted from most pediatric hypertension specialists, and now we know that in all guidelines it is suggested to be the best method to confirm hypertension before starting antihypertensive drug treatment, to exclude masked hypertension and nocturnal hypertension, and also is important to use it routinely to identify abnormal phenotypes in children with diabetes, chronic kidney disease, organ transplantation, obesity with or without the sleep disordered breathing, children after repair of aortic co-attraction, also children that they are receiving antihypertensive treatment to see for the blood pressure control, but also to see for complications like symptoms of hypotension. Next, please. While for home blood pressure, there is evidence from adults that it has a lot of advantages, but at the present we have no data from home blood pressure for the advantages for home, especially for children. So actually all guidelines up to now, pediatric guidelines, suggest that it is useful and complementary to ABPM for the evaluation of effectiveness and safety of antihypertensive treatment. Next, please. The methodology of 24-hour blood pressure monitoring, it's important, and it should be well known from pediatricians and specialists on how to do it, but as it is usually performed on specialist centers, I will not go further and move to the next slide. Next, please. Which is about the methodology of home blood pressure, which, as in the case of office blood pressure, should be performed in a quiet room, comfortable. Again, the child, and especially the adolescents, should avoid smoking, caffeine, eating, or exercise before, because again, this is resting blood pressure. The patient should not talk between the measurements and use all the recommendations and as we see in the figure as for the measurement for office blood pressure. Next, please. And it's important to also that we teach the patient how to take blood pressure at home that again that it is a resting blood pressure, and what is the schedule for evaluating home blood pressure. And currently the most based on evidence from adults, the suggested scheme is to measure blood pressure for 7 consecutive days on a morning and afternoon, and then calculate the mean. And of course, pediatrician can also use home blood pressure to evaluate children under treatment. In cooperation with a specialist, they may use this home blood pressure monitoring schedule as suggested by the HyperChildNET COST Action, and use this one, give it to the patient so that the patient can report his values and then calculate the average of all readings. Next, please. So in conclusion, screening for high blood pressure in children should start at the age of 3. Even at birth, in younger ages, if there is presence of risk factors, diagnosis of hypertension should be established on repeated office blood pressure measuring using a manual auscultatory device. Data from automated devices should be confirmed using a manual auscultatory device because reference data are based on auscultation. If we use electronic devices, this should be validated for patients' ages according to established protocols that you can find in the HyperChildNET COST Action website. The validated devices currently available. Next, please. ABPM is a valuable tool, and it is recommended to establish the diagnosis of hypertension, evaluate of blood pressure phenotypes, and assess the efficacy of treatment. Home blood pressure should be used for diagnosis, but may be considered only for follow-up in children treated for hypertension. Next, please. And last but not least, I want to stress out that the pediatricians and family doctors have a very important task to screen for blood pressure. To screen for blood pressure because they have to decide if a child has hypertension and has to be referred in specialist. And of course now they should be aware of guidelines, but actually they can use our, next please, they can use our calculators in an easy way in their office to find out if the child has a high blood pressure and consider to refer to a specialist. Thank you very much.
Thank you very much, Professor Stabouli, for a very practical lecture. And I would like to ask Professor Koletzko for introduce our last speaker.
Thank you. Yes, our last speaker, last but not least, is Olena Nyankovska. She is a pediatrician and professor at the Lviv National Medical University and the University of Rzeszów. And her topic today is tools to help pediatricians, blood pressure diagnosis, blood pressure categories, the role of calculators. Thank you, Olena, for contributing.
Thank you. Hello, dear colleagues. Good afternoon. Today we will speak about tools to help pediatricians. It's our calculators. Please, next slide. Increasing prevalence of hypertension in children and adolescents has become a significant public health issue, driving a considerable amount of research. Next, please. Proper blood pressure measurement technique has important impact on the accuracy of office BP measurement. Before starting BP measurement, the child should remain seated and relaxed for 3-5 minutes in a quiet and comfortably warm room. They should be seated with their back supported, the legs uncrossed, and the feet flat against the floor. Supine position is not recommended, as it may result in a higher systolic blood pressure. Blood pressure is usually measured on the right arm. The arm should be supported at the heart level. The upper or lower position of the arm results in a lower and higher blood pressure, respectively, due to changes in a hydrostatic pressure. Please, next slide. The appropriate cuff for the arm of a child needs to be selected. A cuff that is too small can overestimate the blood pressure, and a larger cuff may give lower readings. Please, next slide. According to the European Society of Hypertension 2016 guidelines, the BP should be measured 3 times in children and adolescents with an interval of 3 minutes apart, and then evaluate the average of the last 2 readings to determine the child's or adolescent's BP level. In this table, you can see the classification of hypertension in children and adolescents from 0 till 15 years old or 16 years old and older. You can see the category of the systolic blood pressure and diastolic blood pressure percentile and value. Please, next slide. And we have consensus document, European Society of Hypertension guidelines for the measurement of high blood pressure in children and adolescents. This crucial document includes agreed guidelines for pediatricians and clinicians working with children and adolescents. Please, next slide. HyperChildNET is a network for blood pressure research in children and adolescents. 3 types of blood pressure calculators have been created. These tools has been developed by the COST Action HyperChildNET as a useful instrument for pediatricians and other clinical professionals working with children and young people in Europe and elsewhere. The calculator is based on the 2016 European Society of Hypertension guidelines for the management of high blood pressure in children and adolescents. First of all, we will have a look at first calculator. It's pediatric office blood pressure calculator. We fill in this form. It's gender, date of birth, height in cm, second blood pressure, reading value, systolic or maximum, and second blood pressure reading value, diastolic or minimum. And the next one, third blood pressure for systolic or diastolic. And after that, we calculate and receive the result. In this case, it's isolated diastolic hypertension. Please, next slide. The other calculator, the next one, it's pediatric 24 hours ambulatory BP calculator. It's we have the different type of step. Step 1, it's choose the option, and we choose, for example, diagnosis. Please, next slide. After that, we have some points, and after that we choose step 2, reference value by age, and step 3, calculate and receive this type of result. But we can choose the other option. For example, step 2, it can be reference value by height, and in this case we receive calculate, and in this case diastolic hypertension. This next slide. And other option, step 1, we choose goals during treatment. Step 2, reference value by height, and calculate and receive result in percentile. Please, next slide. Blood pressure target in the general hypertensive pediatric population, in the absence of prospective long-term studies on the impact of different BP levels on intermediate or major cardiovascular and renal endpoints in children, the 95th percentile is considered as cutoff for defining hypertension in children and adolescents. This provides a rationale for targeting children and adolescents with essential hypertension to BP below the 95th percentiles for age, sex, and height. But it's probably wiser and safer to aim BP below the 9th percentile, provided this goal can be attained by well-tolerated treatment. And the last one, it's a pediatric home BP calculator. It's calculator to assess at home. Methodological aspect, measured daily on at least 3-4 days. preferably on 7 consecutive days in the morning as well as in the evenings. Measured in a quiet room with the patient in the seated position, back and arm supported after 5 minutes of rest. 2 measurements per occasion, taken 1 or 2 minutes apart. Home blood pressure is the average of these readings with exclusion of the first monitoring day. And we fill in this form gender, height in the cm, systolic or maximum, or diastolic or minimum blood pressure, and calculate. We receive the next result. That's why we have very easy and very useful tools. We have a 3 calculator. You can go right now to this calculator through QR codes and try do it because it's very easy. Next, please. And the use of BP calculators for pediatricians can improve the diagnosis and management of patients with hypertension. Thank you very much. Next slide. Thank you for your attention. Thank you so much.
Thank you a lot for a great presentation with a lot of practical advice. Now, our time has advanced, but I think we still have an opportunity to address at least a few questions, and this will be moderated by Professor Artur Mazur.
Thank you, all speakers and all participants for participants in this webinar. The idea to create this webinars and our statement, but was such because data from literature underlie that only around 25% to maximum 40% of GPs and pediatricians perform blood pressure measurement during the visit, children visit in office. So I do hope that today webinar underlie needing blood pressure measurement and we receive information why, what kind of tools we should use, what kind of methods we should use, and what kind of very helpful tools like blood pressure calculator we should use in everyday practice. And I look for the chat, but unfortunately I don't have any questions.
Maybe I can help you out. There is one question in the chat, which perhaps is for Dorota, and maybe also Stella would like to comment on it. It's the question: when a patient has a higher blood pressure in the doctor's office, but a normal blood pressure at home, what should I do? Should I indicate ABPM? Could I take it as white coat hypertension? What do I do?
Yes, this is thank you. This is an important dilemma because actually ABPM may not be available. The right answer is to, when we have a disagreement between office and ABPM and a home BP in children, we should advise for ambulatory blood pressure monitoring because actually the data we have for home blood pressure are very limited. They are from single center studies. We don't have an analysis from ESCAPE study in children with chronic kidney disease showed no very good sensitivity on diagnosis of hypertension. So actually the right answer, and according to the guidelines, should be to advise to perform an ABPM to be sure. But in case you don't have the availability of ABPM, you may consider keep with home blood pressure and the office blood pressure measurements for a while before referring the child for ABPM.
Thank you for answer. Can we other questions, because I don't see on the chat any more. Berthold, do you see questions on the chat?
No, just Teresa Hermankova was thanking you, Stella, for the answer, but maybe I can a directed question to Empar Lurbe, because you've been putting together this amazing HyperChildNET COST Action, and I think you can be very proud of what you have achieved. You've really provided some great guidance and some very important practical tools. So if you look back at this journey, what do you think is the biggest achievement, and what do you think still needs to be done? What should be focused on in the future?
I think we were very lucky because we have a wonderful team that we are working all together. And I think that is very important. As Professor Hoyer said, the obesity is increasing and is the main cause of hypertension in children. Then the question was, supported by HyperChildNET, we decided to apply to the program of Horizon 2020 of the European Commission for a project based on early prevention of obesity, the main target. We got this project for 5 years with a budget of 10 million euros. And we are starting from the very beginning, taking care of the mother health, and afterwards following the cohort, many cohorts, and from HyperChildNET, looking for some omics, studies in omics from umbilical cord. For example, the offsprings of obese mothers have changes in DNA from umbilical cord. Then these children have a red flag from the beginning. And then this is in which we need to more interest to avoid to develop obesity. Then I think the most important now is to look for the most important cause and more difficult to avoid, that is the prevalence of obesity that is growing and growing and growing, and even is expected to grow more in Europe. And especially the Mediterranean countries have the highest rate of obesity and overweight in children and adolescents. And it is expected that for 2025, only 2 countries in Europe may decrease the prevalence of obesity, Austria and France. 3 will be stable, Czech Republic, Spain, and Ireland. And in the other countries, it is expected that even increase. And I think this is over the world. Then I think this is a main topic that we need to focus on. And now we have the opportunity to continue working together for 5 years more to know how to prevent obesity in children and adolescents, early prevention, starting with the mother health.
Yeah, thank you for these very insightful comments. I couldn't agree more. Early prevention is clearly a priority, and I think as pediatricians, we all know the value of prevention, but perhaps also we need to do even more, that our colleagues are sufficiently aware of issues around hypertension and really do regular blood pressure measurement. I think we also have a gap there between what we should do and what is done in daily practice. Peter Hoyer, I think, has partly addressed it. Artur, I think our time is pretty much run up. Do you think you want to announce the next webinar so people are aware of what's coming?
Yes, I would like to thank you once again for your participation for today. I would like to introduce our webinar for the next week. As I introduced it on the beginning of this webinar, also we are going to have world famous researcher and lecturers in the field of blood pressure measurement. And the next webinar will be focused a little more about the management and treatment, and I think will be also interesting for our audience. And may I say only that please join with us and connect with us and inform others that we have opportunity to receive knowledge on the high levels and how to correct treatment and diagnostic and treatment blood pressure in children during this participation in such a good webinar. Thank you once again, all speakers, and especially you, Professor Berthold Koletzko, that you welcome us and as the President of European Academy of Paediatrics.
It was a pleasure, and I join you in thanking everybody for contributing, all the great speakers and all the participants for your interest. I'm sure you will have taken something home that is valuable for your practice from tomorrow onwards. So congratulations to all the speakers, and have a very good evening.
Thank you very much, and see you soon on the next webinar.